and we want to talk about the 12 pairs of cranial nerves that come off the brain. They actually branch off the brainstem. You can see them pictured on page 71. And I'll just walk you through the picture. I'm not testing you on this. This is not an anatomy class. I'm not going to ask you which one is the oculomotor nerve. But let's just take a look at it. We're looking at the inferior or underside of the brain. And we can see, and the 12 pairs of cranial nerves are identified both by name and by number. And the number is usually written as in Roman numerals. So the first pair are called the olfactory nerves, right and left, or cranial nerve number 1, Roman numeral 1. The next pair are the optic nerves, cranial nerve number 2. The next pair are the oculomotor cranial nerves number 3. The next pair are the trochlear cranial nerves number 4, IV. The next pair, trigeminal, V, the most important cranial nerve in dentistry, number 5. Again, they're paired. Cranial nerve number 6, the abducens, right here. And then cranial nerve number 7, VII, the facial nerve. Then cranial nerve number 8, the vestibulocochlear nerve. Cranial nerve number 9, right and left, is the glossopharyngeal. The largest pair of cranial nerves by far are the huge vagus nerves, number 10. So they're going to be very important. We'll get to that. And then cranial nerve number 11, the accessory cranial nerves. And finally, the hypoglossal cranial nerve number 12. Now, we're just showing you where they come off mostly the brain stem on the bottom side of the brain. And now we want to understand what's in them. What do they do? On page 72. Now, there are 12 pairs of cranial nerves. In this chart, the left-hand column indicates the number of the cranial nerve in Roman numerals, and that's how they're identified. In the second column, the name of the cranial nerve. In the third column, the type of nerve fibers or wires that are inside it. And finally, on the right, the function. Now, I want to begin actually with cranial nerve number 9, IX, the glossopharyngeal. I want to begin with glossopharyngeal cranial nerve. Because the glossopharyngeal, and incidentally, what would glossopharyngeal literally mean? Tongue, throat. So it's the tongue, throat nerve. Glosso means tongue. If somebody has glossitis, they have an infection of their tongue. And pharyngeal, pharynx is throat. So it's the tongue, throat nerve. Now, the glossopharyngeal is the only one of the 12 pairs of cranial nerves that's like a spinal nerve. Why do I say it's like a spinal nerve? Let me remind you, we learned, and this picture goes back to page 28, a spinal nerve, page 28, a spinal nerve contains 4 types of wires. We've also talked about this on the picture you drew on 66A. There's somatic sensory neurons, visceral sensory neurons, somatic motor neurons, and autonomic motor neurons. So we find 4 types of wires in spinal nerves. But there's only one cranial nerve that has all 4 types of wires, and that's the glossopharyngeal. So I kind of drew a nerve here, and I drew 4 different colored lines to represent that it's got 4 different types of wires. Here in the chart, you can see I wrote them. Somatic sensory, visceral sensory, somatic motor, and autonomic motor. It's the only cranial nerve that has all 4 types. The others have fewer than all 4 types. The somatic sensory neurons in the glossopharyngeal nerve are associated with the sense of taste from the tongue. Why did I call it somatic sensory? It's obviously sensory, you're tasting something. I called it somatic because it reaches consciousness. You know, you're aware of what you taste. Many books will call it special sensory. So you might have learned in your anatomy class or another class the term special sensory. Okay, but I'm being consistent. It's somatic sensory in the way I've defined it as reaching consciousness. The visceral sensory neurons Now we know that visceral sensory, the information doesn't normally reach consciousness. So there are baroreceptors and chemoreceptors. Now remember, most sensory neurons have this ending receptor, right? Thermoreceptor, photoreceptor, noxiceptor, right? So these are baroreceptors and chemoreceptors. What's a baroreceptor sensory neuron? It monitors your blood pressure. Baro means pressure, like barometer, barometric. So baroreceptors are the name of the sensory neurons that monitor your blood pressure. Now, why do I say it's visceral sensory? Why do I claim that it's not reaching consciousness?
We're not aware of that.
You're not aware of your blood pressure. Do you think that if you had high blood pressure, you would know?
You can feel headaches or really pressure on your brain.
Do you know that a nickname for having high blood pressure is the silent killer? Why do they call it silent killer? Because you don't know that you've got it. There are millions of people walking around with high blood pressure who don't know it. There's also chemoreceptors, visceral sensory neurons that are monitoring your oxygen and carbon dioxide levels in your blood. Can you feel your carbon dioxide levels? How's it feel? Does it feel a little high today? Feeling low? So we don't feel the oxygen and CO2 levels. If there wasn't any oxygen in the room, you would pass out and die, and you'd never know what you died from. Because you wouldn't say, oh, I think there's not enough oxygen in this room. And you can't walk into a room and say, I think there's enough oxygen here. We don't feel it. But your brain is getting information, and it's being processed at a subconscious level that will affect your breathing pattern. But we just don't feel it. We're not aware of it. There's also somatic motor neurons. Now, somatic motor neurons are motor neurons that are under voluntary control, or at least can be under voluntary control, that affect our skeletal muscles. These control the skeletal muscles in your throat for swallowing. You'd say, what, that's under voluntary control? No, I just swallowed right now. So you can swallow whenever you want. There's the constrictor pharyngeus muscles of your throat that are skeletal muscles under voluntary control. Then there's autonomic motor neurons, also in this glossopharyngeal nerve, that control your salivary glands. Now, I'll just ask you to know that they control the salivary glands, but all of you who are interested in dentistry or dental hygiene, you may as well learn it right now. The autonomic motor neurons in the glossopharyngeal nerve control the parotid salivary glands. Those are the large ones below your ear. So while I'm not asking the class to know it, if you're going into dentistry, dental hygiene, may as well learn it now. You're going to be expected to learn it in the first semester of the program when you have head and neck anatomy. There are 3 sets of salivary glands, and we'll see what controls the other 2 in just a little bit. But the autonomics and the glossopharyngeal control the largest pair, the parotids, below the ear. Now, that's the glossopharyngeal. The next cranial nerves are the largest pair, the vagus, number 10. The vagus cranial nerves have only 3 of the 4 types. They contain visceral sensory neurons, somatic motor neurons, and autonomic motor neurons. Why is the vagus so big? Why is it so important? Inside the vagus nerve are millions of sensory neurons from every internal organ in your chest and abdomen. That means that all the sensory neurons bringing information from your intestine, your stomach, your kidneys, your liver, your gallbladder, your pancreas, your heart, your airways, all travel through the vagus nerve to your brain. They're not going into a spinal nerve, it's actually going directly to your brain, the sensory information. Now, I call it visceral sensory because we don't feel it. All right? We don't feel our internal organs. The somatic mode, also in the vagus nerve, another reason why it's very important, are somatic motor neurons that permit voluntary control over your vocal cords in your larynx. So that means if there's severing or damage to the vagus nerve, you can't speak, which will be a lot like the way I was last week. So anyhow, so that's another reason why it's very important. So that's coming off this vagus nerve off your brain. Also in the vagus cranial nerve are autonomic motor neurons that automatically control every internal organ in your chest and abdomen. So the autonomic control of your heart rate, of your GI motility, of your liver function, of your pancreas, of your gallbladder, of your kidneys, of your intestine, is because of millions of autonomic motor neurons coming off your brain, traveling down this cable called the vagus nerve and sending branches of autonomic motor neurons to all of the internal organs of the body. So when we talk about that case of Christopher Reeve, he had severed his spinal cord right here, but his vagus nerves were still coming off his brain, so he still had autonomic control of his internal organs. See, because you might have asked, then what was controlling his internal organs? But they're coming off through the vagus nerve, right, off the brain. And they have they're long, and they extend all the way down into the organs, internal organs of the chest and abdomen. So the vagus is very important. Now you notice that the bottom two, I did not put in bold print. So of the eight that we're going to emphasize, these are not part of those 8. But I'll mention them. The accessory cranial nerves, number 11, contains somatic sensory and somatic motor neurons. The somatic sensory are associated with sensations from the larynx and neck. And the somatic motor neurons permit voluntary control of your sternocleidomastoid and trapezius muscles. So the sternocleidomastoid, you might remember from anatomy, is the muscle that allows you to flex your neck. And the sternocleidomastoid, and this trapezius is the huge muscle, the major mover of your shoulders. So if anybody wants to go into OT or PT, occupational therapy or physical therapy, then you should definitely know the accessory nerve. Because if somebody has injury to the accessory nerve, then they can't move, they can't flex their neck, and they can't move their shoulders. All right, so if you're going into that, learn it now. You'd say, why would I want to learn something that I don't need to know yet? Because of the intensity of those clinical programs. All right, anyhow, the hypoglossal cranial nerve number 12, again, I'm not going to test you on it. Literally, it means under the tongue, below the tongue, hypoglossal. It contains somatic sensory and somatic motor neurons, all related to your tongue. So it is associated with proprioception from your tongue. What's proprioception? The sensation of movement, kinesthesia, or proprioception. So when you wiggle your tongue, can you feel it moving? Yeah. If there was injury to this nerve, you wouldn't feel it move. Furthermore, it has somatic motor neurons that allow you to move the tongue. So if there's injury to this nerve, you can't move your tongue anymore, which is going to impair your ability to speak. Going to the top, these are in bold print up here. Cranial nerve number 1, the olfactory nerve. It only contains somatic sensory neurons. That's it. So I represented that. I drew a nerve, and all there are is I just put blue wires. They're not really blue. All it has is somatic sensory neurons in it. That's it. No visceral sensory, no somatic motor neurons, no autonomic. It's all somatic sensory neurons associated with the sense of smell from your nose. So the sense of smell is called olfaction. So why did obviously smelling is sensory information. Why did I call it somatic? Because it reaches consciousness. You're aware of the odors that you detect in the air. You can smell whether there's garlic, or whether there's onions, or whether there's gardenias or roses. All right, you're aware of that. The optic nerve, cranial nerve number 2. Again, it's just like the olfactory. All it has is millions of somatic sensory neurons in wires inside it. These are associated with the sense of vision from the eyes. So in other words, coming off the back of your eyeballs, and we're going to learn more about this, is the optic nerves, and those optic nerves are like cables that connect right into your brain, and inside these cables called optic nerves are just millions of wires from your eyes. And they're sending nerve impulses, action potentials, and your brain is converting these electrical signals into a visual image. And if you're thinking, how could that be? Ask how a television set works, how your computer works. How's it getting these visual images on the screen of your computer? It's all electrical signals. That's the optic nerve. Incidentally, again, if you may have learned in another anatomy class or another class, they might have called it a special sensory, all right, instead of somatic sensory. Let me just do one last one, and then we take a break here and finish it off after the break. The oculomotor. Oculomotor. Cranial nerve number 3. It has 2 types of motor neurons, somatic motor neurons and autonomic motor neurons. The somatic motor neurons permit voluntary control of your eye muscles. You might have learned in anatomy about how you have superior rectus and inferior rectus and medial rectus and lateral rectus. These muscles that can rotate your eyes up and down and laterally and medially. They're skeletal muscles. They're under voluntary control through your somatic motor neurons that are inside the oculomotor cranial nerve. There's also autonomic motor neurons. Incidentally, you may have noticed that wherever I wrote that word autonomic, I put in brackets right above it the word parasympathetic. We're going to be explaining that. I haven't gotten to that yet, but we will explain that it's a certain type of autonomic called a parasympathetic autonomic. But we'll get to that, not today. These autonomic motor neurons permit automatic control of the iris muscle of your eye. So let me just explain this, and then we'll take a break. Here's an extraordinarily bad, poor picture of the eye. We're going to see a good picture, all right, later. But this is a bad picture of the eye. The black spot in the very center is called the pupil. The pupil is really a hole through which rays of light enter your eye. Surrounding the pupil is a pigmented muscle called the iris. The iris is made up of muscle cells, visceral smooth muscle cells. These muscle cells are pigmented. They may be pigmented blue or green or brown or hazel or some combination, and so they just happen to be pigmented muscle cells. But it's a muscle. This muscle can contract or relax, and depending upon whether it contracts or relaxes, that widens or closes the hole, the pupil. So this is automatically controlled by autonomic motor neurons. When you walk into a dark theater, you don't have to say, let's see, let me make my eyes get bigger. It just automatically happens, right? You've got light sensors, and we'll get into that, and it automatically is going to cause this muscle to contract and dilate your pupils. And when you come back out of the theater, if it's a daytime matinee and it's bright and sunny out, then it's going to be too bright and it's automatically going to close down the pupil size. So this is autonomic motor. But if there's damage to the oculomotor nerve, it affects the movement of your voluntary movement of your eyes and will affect the automatic opening and closing of the pupil.
Oh.
So one of the things they do, and I'll finish with it. So if somebody is worried about maybe brain damage, they'll say, shine a flashlight into their eyes. We want to see, do we see this pupillary light reflex? Since it involves nerves coming off the brain, right? This thing, if this doesn't work, there's a problem in that brain, because these are cranial nerves. They're coming off the brain. And the trochlear cranial nerve, you'll notice, is not in bold print. Inside it are just somatic motor neurons that control one of those eye muscles. So they call it the superior oblique. The next cranial nerve, very, very important, number 5, the trigeminal nerve. The trigeminal nerve is the most important cranial nerve for dentistry, dental hygiene. Inside it are somatic sensory neurons and somatic motor neurons. The somatic sensory neurons are associated with sensation from the entire face, including all the teeth. And the somatic motor neurons permit voluntary control over the chewing muscles, the muscles for chewing, such as the masseter, for mastication. To help you visualize that better, let's look on page 73. On the top of page 73. This is a picture. Those of you who had me for anatomy will recognize that I use this picture in my anatomy lecture outline as well. And we'll just show you the trigeminal nerve. It gets its name trigeminal because it has 3 branches. These are the 3 branches are known as the ophthalmic branch, the maxillary branch, and the mandibular branch of the trigeminal nerve. Inside the ophthalmic branch are millions of somatic sensory neurons providing sensation from the forehead, around the eyes. That's why it's called ophthalmic. In the middle branch, the maxillary branch, are millions of somatic sensory neurons from the nose, the upper jaw, including all the upper teeth. In the lower mandibular branch of the trigeminal nerve are millions of somatic sensory neurons providing sensation from the tongue as well as the lower jaw, including the lower teeth. There's also another branch off that mandibular branch of the trigeminal nerve that contains somatic motor neurons that permit voluntary control of these chewing muscles, like the masseter and so on. So the way this works in the world of dentistry is that both dentists and dental hygienists are licensed, trained and licensed to give local anesthetics. We've talked about local anesthetics, like lidocaine, that they temporarily block the conduction of action potentials in nerve fibers. So let's say a dentist wants to is going to be doing some dental work on an upper right tooth. So they want to inject the lidocaine into the right trigeminal nerve, specifically the maxillary branch of the right trigeminal nerve. So they're trained where to give the injection so that the local anesthetic numbs the maxillary branch. So you'll get loss of sensation, anesthesia on the right side of the face if they only blocked the right trigeminal nerve and just the upper teeth. Now, if the dental work is being done on the lower tooth, like again, let's say it's the right lower side, so you're trained where to give the local anesthetic to block a nerve conduction in the mandibular branch of the right trigeminal nerve. When they block that, not only do you lose sensation from the lower teeth, you also lose it in your tongue. So you lose both. Where you give it, though, is you actually block right in here, so you don't block. You don't want to block the somatic motor neurons that permit opening and closing of your jaw, because then they wouldn't be able to tell you to, okay, open up a little wider, close down a little bit. They don't want to block that. Remember, local anesthetic will block conduction in all excitable cells, not only sensory, but even motor, and of course, even muscle cells, so depending upon where it's injected. So that's the idea. And dental hygienists are trained to give these injections as well. Sometimes they're dealing with somebody with hypersensitive teeth, and just the process of cleaning the teeth is so painful that they actually have to give them local anesthetic. It's not common, but it happens. All right, so that's the trigeminal. Back on our cranial nerve chart, cranial nerve number 6, the abducens, is also not in bold print. It just contains somatic motor neurons that control the lateral rectus muscle, which rotates your eyes laterally. So I won't test you on that. The facial cranial nerve, that's an important one. Cranial nerve number 7. Inside it are somatic sensory neurons, somatic motor neurons, and autonomic motor neurons. The somatic sensory neurons provide sensation of taste from your tongue. Now, you might say, wait a second, Professor Fink. You told us that the Glossopharyngeal cranial nerve number 9 had somatic sensory neurons associated with taste from the tongue, and now you're telling us that the facial nerve has somatic sensory neurons associated with taste from the tongue. Which is it? It's both, because we have more than one type of taste. Now, I'm not asking you which taste is communicated inside by the sensory neurons of which cranial nerve, but it's in both. Also in the facial nerve, very importantly, are somatic motor neurons that allow the voluntary contraction of your facial muscles. And you might have learned in anatomy about the orbicularis oculi and the orbicularis oris and the zygomaticus and the buccinator and all these facial muscles which are controlled by somatic motor neurons in the facial nerve. And finally in the facial nerve are autonomic motor neurons that automatically control salivary glands. Now we'll just say salivary glands, but for the future dental hygienists, and you know who you are, so you should memorize it's the submandibular and sublingual salivary glands. You might remember that in the glossopharyngeal there were autonomics to the parotid salivary gland. So it's different. Now to help us visualize this, again, let's look on page 73. Page 73. In fact, you might even say, I can't even read what you wrote there. It's okay, it's on page 73. So on the lower picture on page 73, this is showing the facial nerve. You'd say, where does it say it? It says it right here, cranial nerve number 7, the facial. And this is the facial nerve. Let's see what it does. First, it has somatic motor neurons innervating all these facial muscles. The orbicularis oculi, the orbicularis oris, the frontalis, the zygomaticus, the buccinator. So if there's damage to the facial nerve, you won't be able to move your facial muscles. There's also autonomic motor neurons that are innervating, here they are, the sublingual and submandibular salivary glands, as opposed to the parotid. Also the autonomics innervate the lacrimal gland. What the heck's the lacrimal gland?
Tears.
That's the tear gland. So that's also innervated by branches, autonomic motor neurons in the facial nerve. And there's somatic sensory neurons from the tongue associated with the sense of taste. Now, what if somebody had injury or even an infection in the facial nerve? So if the facial nerve doesn't work, then all the things that we just told you it's associated with ain't gonna happen.
There is a virus at the back.
You're exactly right. Anybody know what the viral infection of the facial nerve is called?
Some Polsky something. Polsky is
Not Polsky. That was the guy who lives in Poland. But no, it's called Bell's palsy, and it's on the next page. It's page 74. It's called Bell's palsy. Now, Bell's palsy, as we wrote here, as is written here, oops, turn that back on. Bell's palsy is a viral infection of the facial nerve. In theory, the virus could infect either the right or the left facial nerve, or both. For some reason, we don't know why, it usually infects the left facial nerve. Usually. Doesn't have to be, but it's usually. And as long as the nerve, the virus is in the nerve stops working. So the person actually has paralysis of the facial muscles on the side of their face where that facial nerve is not working. So usually it's the left facial nerve, so their whole left side of their face is paralyzed. They can't move any of the facial muscles. They can't smile on their left side. They can't wink and blink on their left side. They also have trouble, you can actually see this in the picture of this guy here, since their autonomic motor neurons, he's paralyzed on this side, since the autonomic motor neurons normally control salivation and tearing, there's a loss of control of tearing and salivation on that side, controlled by the autonomic motor neurons in that facial nerve. He even lose sensation of certain taste on half of his tongue. Now, the virus usually will go away on its own. You'd say, how? The same way any virus goes away. When you get a flu, the flu is caused by a virus, or a cold, which is caused by a virus. It just usually goes away. After a few days or a week, your cold or your flu goes away. How? Your immune system. We don't have drugs that are very effective antiviral agents. So it's really up to your immune system. So there's really nothing that can be done when somebody has Bell's palsy. Most people, the Bell's palsy will go away on its own in about 3 months. But there are people who have had Bell's palsy, paralysis of their face, and these other problems for years, and just doesn't go away. Now, one of the cool things about the internet and things like YouTube is you can find almost anything nowadays on YouTube. So, in fact, here's neurophysiology, synaptic transmission, organization of the spinal cord. Obviously, what am I suggesting you do? Look at these. And here, let's take a look at Bell's palsy, a viral infection of the cranial nerve.
Tell everybody what's wrong with you. I was diagnosed yesterday with Bell's palsy, which is a disease in which paralyzes talk, the worse the poll apparently gets. Oh, my phone's ringing. I need to really pick it up.
All right, well, you can watch her the video. She's pretty cool about it, but she tries to show you facial expressions that she's unable to do because she's got paralysis on one side of her face. So, incidentally, also linked on my website are the various clinical, the testing that is done to test for all of the cranial nerve. Back on our cranial nerve chart, there is one last cranial nerve to mention. Cranial nerve number 8, the vestibulocochlear nerve. Now, the vestibulocochlear nerve contains only somatic sensory neurons. In that respect, it's like the cranial nerve number 1 and number 2, which were also just somatic sensory neurons. It's associated with the sense of hearing and balance. Sense of hearing and balance. Now, the structure for hearing in our inner ear is called the cochlea. And the structure for balance and equilibrium in our inner ear is called the vestibular apparatus. And that's why the name of this nerve is the vestibulocochlear nerve.